All right. Can you hear me?
Yes.
Yes.
Okay. So in the name of the MIFAB organization, it's my great pleasure to welcome everyone today to this month's MIFAB lecture. And our honorable speaker today is Dr. Haibo Lin. Am I spelling it correct?
That's correct. Thank you.
A renowned figure in the field of proton therapy, Dr. Lin is an associate research professor and director of the medical physics section at the New York Proton Center. And he is an adjunct faculty member at both Memorial Sloan Kettering Cancer Center and Albert Einstein School of Medicine in New York. Dr. Lin received his PhD in physics from University of Missouri in 2009. Then he moved to University of Pennsylvania, where he did his training in medical physics, and later on was appointed as a lead proton physicist at UPenn Proton Center. Dr. Lin's work focuses on proton therapy, radiation dosimetry, treatment planning, motion management. In addition, that he is a pioneer in advanced radiotherapy techniques such as flash RT and SFRT. Dr. Lin is an active member of many prestigious professional societies such as AAPM, ASTRO, IAEA, and others. He has more than 50 peer-reviewed publications, 5 book chapters, and more than 140 conference abstracts. He is also an editorial member of the Journal of Medical Physics, Journal of Applied Clinical Medical Physics, Cancers and Frontiers in Oncology. More recently, Dr. Lin, in recognition of his outstanding contribution to the field, he received the 2023 AAPM Fellow Status Award. Today, Dr. Lin will share his experience with us on clinical applications of pencil beam scanning proton therapy, opportunities and challenges. Dr. Lin, the microphone is yours.
Thank you very much for the invitation and the introduction, Dr. Niham. And good morning, good afternoon, good evening, everyone. So it's a great pleasure to speak in the Middle East Federation of Organization of Medical Physics. So today I'm going to talk about clinical applications of pencil beam scanning proton therapy, which is the current technology for proton delivery, talk about the opportunities and the challenges. So this is my disclosure. We have some collaborations with Varian regarding the research grant and also some honorary. In the next 40 to 50 minutes, I will start first have a brief introduction about New York Proton Center, and then we will talk about what proton therapy can bring us, mainly from physics perspective, and talk about benefit, and then we move into the next phase, which is a challenge, and then we talk about some future directions. So New York Proton Center is the first proton center and only one in New York State. We are located in the North Manhattan, Harlem area. We started the first treatment in August 2019. We just celebrated the 5th anniversary. And so far we treated 5,000 patients in 5 years. This is include like 2 or 3 years pandemic period. Currently we are pretty much in the full load, 100 to 110 patients in 16 hours operation. Luckily, we are consortium with 3 large hospitals in the New York area, which is Montefiore, MSKCC, and Mount Sinai. So overall, we have 25 physicians practice in our center. And here is the layout of the center. We have the cyclotron. We have 3 gantry rooms and also 1 fixed beam room. These are 4 clinical rooms for patient treatment. At the end of the beam line, we also have a research room here. So both the research room and one of the gantry rooms have the capability to deliver ultra high dose rate proton therapy, which is, often we call flash therapy. This is the disease mix for the 5 years. And here I just pull out some numbers from the National Association of Proton Therapy. And we are not like, like high prostate treatment center. We are only 7%. We started with 3%. Now it's like keep increasing because of the SBRT of prostate. Nationwide, they have 24%. Also, we are big head neck treatment center. We have 29 right now. We started with around 40% of head neck. So nationwide is 14%. Also, we treat 41% of re-irradiation. This definitely increase the complexities of the cases we are treating. And besides that, we are also leading the effort for SBRT treatment. Average we have 10.5%, but just for this year we have 13.8% so far. Adaptive rate, which is slightly different to what you see on the conventional side. Later we'll talk about, proton is more sensitive to any changes on the beam path or anatomy. So the adaptive rate we have is 16.5%. Some centers have adaptive rate over 20% or even close to 30% because, different approaches they use and different way to identify the adaptive. So let's look at some opportunities with proton therapy. Start with something we are familiar with. 3 major particles used for radiotherapy. And here you can clearly see that the electron, proton, they are in the same category, which is charged particle. They deposit energy through the direct ionization. The differences are the mass differences. There are more than 1,800 different heavier for protons. So because of that, the dose deposition approach is slightly different. For electrons, because the very light mass, so it's just like ping pong ball is bouncing around. And although we see limited range of electron in media, but we don't see the very sharp Bragg peak we see typically in the proton. That's because of the scattering. Photon on the other side is, not a charged particle. It interacts with media with the indirect ionization as massless. So just look at the photon itself. I think everybody is familiar with this. Photon is dominant with the Compton effect. During these interactions, photon actually have continuous reduced fluence in the beam path, which is later we'll talk about proton. It's different. Regarding IDD, this is the photon IDD, and it starts with very low skin dose and then build up to a peak and then dropping following the fluence decrease exponentially like this. And one thing I want to point out is this surface dose for photon. When photon transferred energy to electron, typically the energy transfer is in keV range. So that just set the electron moving forwardly and to a certain distance before it deposit all its energy. That's why you see this build-up region. And later we will see why in proton we don't see this skin sparing. For protons interaction, because it's charged particle, so it interacts with media by Coulomb interaction, either with electrons or with nucleus, where the interaction with electron in ionization is dominant in the whole process. Here I want to point out when proton interact with electron, because the mass differences, typically the proton trajectory won't change. So in that process, the number of protons will not be reduced. That means the fluence is the same, and it only reduces the energy of the proton itself. Then when the proton interact with nucleus, because nucleus typically is much heavy than the proton, so it definitely will change the trajectory of proton, depending on the interaction distances. For example, there are large distance and small angle deflection. And when it's getting closer, there's a large angle. When it has really high energy and can get very close to nucleus, and then there's a secondary particle actually get kicked out. During this process, because the beam angle change, you do see some fluorescence change. So those are different, but the dominant is ionization, which is this process, only reduce the proton energy, not the fluorescence itself. So let's look at the Bragg peak, which many of you heard about the name. So this is a proton IDD. You can see there's a plateau region. There's no buildup at all. It's just like plateau and gradually comes in, and then at the end of the proton trajectory, most of the energy or the dose actually are deposited in the Bragg peak region. Here's the PSI did some Monte Carlo simulation. The blue dot basically shows you the possibility of interactions between proton and electrons. You can see the density is much higher, and this is just a single spot of proton travel in the media. And you can clearly see from the dose calowash, the dose actually is much higher at the Bragg peak region. The reason we call it pencil beam is because this delivery technique actually deliver a circular, spherical, symmetric sport actually into the media. And we can describe this by a Gaussian distribution pretty much. However, if we look at the Bragg peak itself in the depth direction, it won't be able to provide us any like uniform dose. So in order to do that, we need to spread out the Bragg peak. So this is what happened. We have the different proton energies, which is described by each of the small peaks, and they have the highest energy, has the highest weighting, and then continuously reduce the energy and also reduce the weighting of that proton layer. So during this process, we expand the uniform plateau region at the Bragg peak region that we can place the tumor over in this region. So during this SVP generation, I want to point out a couple of things. First is the surface dose. You don't see the skin sparing because when the proton passes the energy to electron, this energy range is in the KV range, in the EV range. Because of the EV range, the electron won't be able to travel much distance, and it will most likely just deposit the energy locally. So when the proton enter the media, the dose accumulation or deposition immediately start. That's why you don't have skin sparing. Secondly, with more and more Bragg peak with low energy building, you can see this dark blue curve, and the surface dose keeps increasing. If you have single field, your surface dose can be like around 70%, which is super high. And second item that I want to point out is the distal end. You can see when the Bragg peak drop to 0, there's no exit dose. So often we take advantage of this area to protect the critical organs. I think this is a very common picture, just show you the photon versus proton SOBP, how it looks like. Apparently proton wing and on the proximal end, also 0 dose on the distal end. And the bottom shows you that you have a target that with proton you can precisely control the energy of the proton of each layer to generate a very conformal dose on the distal end and a 0 dose beyond that point. So with that, you can protect your critical organs at the same time, leave some rooms for your dose escalation if physicians think that the dose to the target is not sufficient. You basically provide opportunity to safely introduce the dose escalation. So let's look at how the proton system works. If we have a cyclotron, actually the proton to have 250 MeV, which is corresponding to like 38 cm in water, and then these protons actually extracted to the beamline and transferred to the treatment room, and then you have a target. This red as the target. The first thing is this 250 MeV is energy is too high. It's going to penetrate through the patient body, so you're going to reduce the energy, which is called energy degrader. It's generated by 3 pairs of graphite, and they can move in and out, so continuously tune the energy down. So for example, you first, based on planning, we find out the most distal or deepest point of your target, and then first move your wedges in and tune the energy to this appropriate energy, and you start to deliver first, second, and third spot. After you deliver the most distal layer, this just to show you the spot that in this layer, and then you deliver all of them, you basically pause the beam, and then this energy degrader moves in and reduce the proton energy to next layer. And then you continue to deliver and ping the spot by spot until this process can just go and on until you deliver all the layers and you get a conformal dose. So different to the old technique like passive scanning and uniform scanning, the pencil beam scanning can generate the conformal dose on both distal end and the proximal end. That's the benefit. If you have a synchrotron system, so that basically replace the cyclotron and the energy degrader, the synchrotron can continue to tune the energy to what you need for clinic. So talk about the planning. There are two ways to plan SFO and MFO, single field optimization, multi-field optimization. Let's look at an example and then see what the difference is between these two. So this is the SFO. If I have this L-shaped target and I have two beams, one from posterior, one from lateral. SFO means that each field will uniformly cover your target volume and together give you a uniform coverage to the target volume. Well, MFO doesn't care about field dose, only care that when you have two beams and together give you a uniform coverage to the target volume. So as a result, MFO knows that this is a critical organ, and in order to maximize organ protection, this field only deliver 100% here, partial over here, zero dose over there. And then the other beam actually in opposite way, 100% here, corner, 50%, and zero on the other side. And together, you also get the uniform dose coverage, but get maximized sparing of the critical organs. So SF, this just tell you the concept of this tool. One example, this head neck case, SFO on the top, you can see each beam actually, based on the color wash, they are quite balanced regarding the dose contribution. But the MFO on the bottom, you can see that they contribute more dose on the beam side, but if it's far away from the beam side, it contributed less dose. This is like through the inverse optimization process. But and together, you don't see much difference between them. Okay. And then let's look at a couple examples. These are basically the two examples. On the left side shows you the CSI photon versus the proton. And because the proton has non-exit dose, you can see that the advantage is you protect all the anterior organs in the chest and the abdomen. For the breast, because we use anterior beam, so the dose actually is really conformal and follow the chest wall here, and can reduce the dose spilled into a heart and the lung. Those are the benefits. One important or unique planning strategy we have is this gradient dose match. I know IMRT can do the similar thing. This just shows you for the CSI case, for brain, we have the dose in the junction area taping down and spine taping up. As a result, this is a dose profile. You can see that continuous dropping and continuous increasing, and together get a uniform dose. So we don't do like hard dose match. That can reduce the sensitivity of the delivery to any setup errors. And this technique actually used pretty widely in clinic. For example, this is the head neck case. We treat with posterior beam for anything above chin, and then for the anterior neck node, and single anterior beam can cover all the nodes. As a result, we can maximize sparing anything like oral cavity and also the spine for the neck area. And the other things like whole pelvis, we treat with two lateral beams for the prostate and then posterior to the node, so that we can maximize the protection of rectum and also the bowel. So this is an important features for compact proton system when your field size is limited and you're treating large target. And the other application, include the RT. This is a good example. We have patient received priority to the brain area, and the brainstem receive more than 54 gray already, and then come back for a CSI treatment. So we planned with two lateral field. You can see 100% dose from the right side and 50% on the anterior side target, and opted on the other 100%, 50%. And together, you basically can crop the dose in the middle, where already received significant dose from the prior treatment. And this is and together the dose, you can see we basically cropped out the area we think is high risk if we deliver the prescribed dose again over there. So this is the benefit of proton therapy. And second case I want to show you, also CSI. The patient is 7 months pregnant and need to get the urgent CSI treatment. This is from UPenn. They published this paper in 2018. And the patient also received a boost on the brain area. So bottom shows you the brain. So it's not like we encourage to treat such kind of patient. It's just like, proton therapy can provide some new hopes to some of group patients who are probably not appropriate or in a high risk if we deliver the RT to those group patients with a photon therapy. And here shows you a very interesting publication from our group, and basically the physicists actually just contoured everything and then try to mimic the femur's painting here. And this is based on the ice dose curve, and this is the color wash. And on the right side, it shows you the spot map itself. Just want to tell people that with pencil beam scanning proton therapy, you can achieve very conformal dose around your critical organs, try to cover your target volume. As long as you gave a go, we can try to achieve that. And from some extent, it gives us more flexibility and rooms to optimize the dose than the photon therapy, especially you give very limited constraint to critical organs. Okay, let's look at some challenges. We talk about some good things about proton therapy. For protons, that when we talk about the clinical, we cannot avoid mention uncertainties. Why it matters? Let's look at the simple example. And this is the photon IDD. If we unexpectedly insert 3 cm bone in the beam path, and you will see that the dose beyond the bone actually dropped by 11%. If you have a target here, you still receive 89% of the prescribed dose. And for proton, if you insert 3 cm bone, it will pull your SOVP or Bragg peak to the shallow depths by around 2 cm. So originally, if you have your target volume over in this region, then that means you may drop your coverage from 100% to 0%. So your range uncertainty eventually will translate to the dose errors and cause significant discrepancy between what you deliver dose and to what you plan dose. Ultimately, if you have some cavity appeared in the beam path, this Bragg peak will overshooting to the deeper depths. Remember, often we try to use the zero dose on the zero exit dose on the distal end, try to protect some critical organs here. And then that means originally your critical organ received 0 dose, now it can be flooded by the prescribed dose. That's why the uncertainty is a critical topic. And during planning stage, we have to consider it. We have to try to predict what can happen and try to plan in a way to be more conservative and either ensure we have enough coverage or make sure critical organs, especially serial organ, are safe during those uncertainties. This is one example for lung cancer treatment. You can see that we planned with posterior beams over try to cover this target. You also see the advantages. We basically delivered almost 0 dose to the opposite lung, and and only limit those to the local area. However, if during treatment there's any change on the beam path, for here is like effusion or any fluid appeared, you can imagine that the proton will stop in a shallow depths because it's going to pull back, and you can see the color wash that we lost some coverage on the distal end. Because we planted multiple beam, it's not like totally pull back to zero dose, but we definitely lose some coverage. This is quite common, those are the two additional cases. And oppositely, if you originally during simulation you have fluid and then patient has some like response or the fluid get absorbed, and then you're going to overshooting, and then the distal organ will receive more dose. So that's the reason, that's the strong reason that during proton therapy we need a con beam CT or volumetric imaging to constantly watching and evaluate the treatment quality. Another example, this is also a long case that just show you a single beam, try to cover this large mass. And this is a 45 gray color wash. If we don't consider any range uncertainties, your cord is safe. But when there's any uncertainty considered, basically your cord is overdose or definitely reach dose level of 45 gray and above. Because of that reason, often we don't point all the beams towards critical organ. For this case, we might end a beam from posterior and put the cord on the lateral side so that when there's any range uncertainties, we don't flood the critical organs by the prescribed dose. So in our institution, we have the rule that no more than 2/3 of the prescribed dose point towards the critical organ. Some institution has the criteria of 50%. The other one is the uncertainties come from the moving target. I think this is also a challenge for the photon side, but proton, especially pencil beam scanning, is much more sensitive to that. And often you plant a dose in a static imaging and get very uniform dose, but consider the motion, you get very heterogeneous dose, which you need to consider during the planning stage. And often, once the simulation is done, we need to do the motion evaluation. And most time, we evaluate the motion amplitude. This is the histogram based on the 4D CT. But for proton, more importantly, we also need to understand at different beam angles, due to this respiratory motion, what are the vertical thickness changes on different beam angles. This help us to select more robust beam angle, less sensitive to any organ motion caused the beam overshooting, undershooting. And you can imagine that this diaphragm moves in and out, and then you have proton just shooting laterally like this, and your beam is going to overshooting or undershooting depending on where the diaphragm is. That's why the largest WT change for this case is at gantry 90 from this direction. So regarding the motion mitigation, there are some common approaches. For example, ITV approach, and there are abdomen compression belt, and there are DIBH, they are gated delivery. And for proton, there are also other approaches. For example, we do rescanning, repainting. That means we deliver the same beam multiple times and use time to smear the dose. There are also approaches to use a 4D optimization. That means the optimization is based on the average CT plus inhale CT and exhale CT. So the optimization try to come up a balance of dose distribution and consider these three scenarios. And at any scenarios, the target coverage is still guaranteed, and also the dose to the critical organs are maintained. And the other way is to try to increase the spot size. You can think about it like, when you scan a target or paint a target with a brush. If your brush is much larger, then it's less sensitive to the motion. Fractionation is another way to repaint or rescanning, but often for SBRT, it's not because of limited fractionation, you won't be able to repeat enough time. That's why for SBRTs, we actually copy paste field multiple times and then repeat. And that also increase the total number of beam can be up to like 10 field or 12 field and extend the deliver time. Metal is another one. It's also challenging for photon, but proton, because we're quite sensitive to any beam path heterogeneity changes. So often we need to design the field specific target volume and try to crop the metal area from the beam. And this is one example of beam come from this direction. And apparently this metal will cause some shadow effect. And then we crop the target. So this blue target is the area that allow the optimizer to place the proton spot. So you basically limit the any proton passing through these metals. And this is also a metal, we allow the beam to deposit those in front of this metal, but not beyond it. So as a result, we can plan multiple beams, and you can see the field dose of each of them, and basically try to avoid shooting through the metals. Of course, if you can ensure every day you have the metal in the same place, you can align very well, and they are not moving from day to day. And also you have very good model of these metals in CT, and you also have Monte Carlo calculation algorithm. You probably can consider shoot through it. But if the metal actually moves every day, that can be a problem. So, and together, all the dose looks like this. It's not too bad. We have some cold spot, but overall, this is a 90% of isodose. You can see, it's pretty good coverage. And also we have a capability to try to cool down the spinal cord in the middle. So next item is the RBE, or biological effectiveness. So in proton therapy, we know that we use 1.1. This is that means the proton has more damage than photon by around 10%. But this 10% is the average number. So if we look at this data, you can see this this curve is the physical dose, and this is the biological effective dose. And in this effective dose, especially in the SOBP region, this is around 1.1 here. But in the distal end, apparently there's an enhancement here. This enhancement, some of the biology studies show that it can be like reached to even 1.3 or to 1.5. So luckily, this is we know this effect, so we can consider it during the plant delivery. That means we have to use a multiple beam and with the large angle separations, so your distal end won't overlap with each other. That comes to the same conclusion that we allow no more than 2/3 of the beam point towards critical organs. And many of the consensus actually recommend 1.1, but recently more and more people looking into more details about this modeling, this enhancement at the distal end. So RBE itself is a parameter that associated with a lot of biology parameters. So it depends on the tissue, cells, and energy. So physicists actually are smart enough. They are looking at RBE and same time realize that LET, linear energy transfer, this parameter is more physical. It's pure the beam property. It doesn't correlate to any like biology or tissue type. So they actually started using LET, do optimization, try to reduce the LET so that in a critical organ area, and also try to increase the LET in the target area, so we can cause more damage in the targeted region and reduce the damage to the critical organ area. So this is a study from Mayo Clinic, and on the top shows you the LET distribution, and the bottom shows you the dose. And you can see that this figure, and in the target region, you have a cold spot for LET, and this is the brainstem. You can see it's relatively higher, but after the LET optimization, you can see it's more uniform in the target region, and there's like a little bit better, I would say, from color wash point of view in the brainstem area. But dose-wise, they are the same. So that means we have a room to optimize LET and reduce any potential toxicities caused by this distal enhanced or biological effectiveness. The other thing is adaptive I want to mention. This just to group the cause of adaptive. We have 16.5% of root rate, and the major contribution is from the anatomy change or beam path changes. And I mentioned when that changes, your target coverage can significantly drop, your critical organ can have significant increase the dose received. So those are the main contributions. So to trigger those con-beam CTs, one, periodically re-simulate the patient and forward calculate the dose and evaluate the treatment quality is another way. And also we closely monitor the patient weight. If there are quite some of like weight changes, we also need to re-sim the patient and see how the weight change impacted the treatment quality. So far, there's only one case that we cannot handle with Proton because of daily variations. This is the case that the liver case. We have two targets, large area CTV1 and small area of CTV2. So the plan originally planned with these three beams covered the large area and anterior beam, and this beam covered the small area. But during the treatment, you can see because the target is next to the stomach, and depending on the stomach filling, and this target depth is changing. So as a result, we have to separate this beam because we don't want to deliver the plan so that we cannot hit the target. So after separate this field, like this target only shoot by these two beams, and this target shoot by three beams. We still can deliver beam to this target, but still have challenge to meet this one, even we did adaptive. The reason is because every day it changed. At the end, physician has to drop this target and only treat this part. This is so far the only case among these 5,000 cases that we can't treat with Proton because we can't get the target in the same location or same depth, and depth arrow will translate to those arrows, and we can't hit the target or deliver extra dose to the critical organs, which is not what we want. And I want to point out Proton therapy is labor intensive, so we involve a lot of complexities, and we work long hours. And one example, I don't know, for everybody in the webinar, how many planning cases actually each dosimetry or planner generate every week. For Proton, you can typically generate 3 to 4 cases per week, and that's because of the complexity and difficulties. So we also create multiple layers in the process so that can pick up any errors. And also the high adaptive rate just put a lot of time pressure to the whole team. Here, I just want to see that physics is the core for those challenges, and they coordinate effort and resources, and they deserve high respect. So future directions, I want to point out 3 things. First is SBRT, and second SFRT, and last one is the flash. So I think I don't need to speak too much about SBRT. In the Photon, it's keep expanding. We see some very good outcome results from SBRT. Here's the same, and we have actually keep increasing SBRT rate from 2019. We have this first year opening. We don't have many patients, but from second year we have around 7.5% increase to now up close to 14%, almost double percentage. So this is from one hand we see good results. outcome. And on the other side, physician also be aware that this biological effect, those that the proton can have a better control of the tumors and this high LET. And also this, non-exit dose allow us to do the dose escalation and then, leave the dose to the local area. This is the one example of photon long SBRT versus proton, and you can clearly see that the dosimetric benefit of proton therapy. And the bottom shows you a couple of cases. This is a liver case, and we have beam all from a corner. In this situation, if we have cone beam CT, I don't care too much about alignment in this area. I only care about on the corner and target actually aligned well. And the middle part is this brain case, and you can see we also can limit those to very local region. And this is something totally different and unique at the New York Proton Center. We treat this melanoma ocular treatment with a proton as well, and try to localize the dose just to the disease area, and has very limited dose spilled out to the other side or outside of the target region. So next one is SFRT, spatial fractionated radiotherapy. This is something like recent 1 or 2 years attract more and more attention. Many of institutions start looking this in United States and also try to implement in the clinic. We already treat the one case with proton for lattice. So there are 2 ways. One is grid, typically we call it 2D SFRT, and lattice is 3D SFRT. And if you're interested, this is a very good resource from Dr. Xiaodong Wu. Here shows you what you do, and you have this GTV, and you basically leave a margin and then find the inner GTV, and then you define some high dose region. You optimize those and to achieve this kind of like a lattice therapy. This is the example of proton therapy. You can see this red is the GTV, and then you find this blue target, which is you leave an internal 10 millimeter margin there, and then you define this vertex, which is the green high dose region, and then you optimize them. This is the SFO and the MFO optimized. So the whole target receive uniform low dose. I think from based on this, we can see the vertex diameter, which is the red yellow areas, 0.5 to 1.5 cm, and then the separation is 2 to 5 cm. And if you look at the high dose region, which is in the yellow region versus the overall GTV, it's 1 to 10%, and there's a larger area we can play with. The dose to the vertex is 10 to 25, which is the yellow region, and the dose to the valley typically less than 5 gray. For our case, we plan with 3 gray. And so this is basically the proton example we actually planned in our center. So in US, they are like Radiosurgery Society and AAPM, they all actually established a working group and try to promote this and try to standardize the practice, clinical practice of this SFRT. Last item, I think many of you probably heard about the flash therapy, and this is a top 10 breakthrough in 2022 from the physics world. And this is about the first trial in human, happening in Cincinnati. So this is a variant-sponsored flash clinical trial. The first 01, which is the one mentioned in the physics world, and this is enrolled 10 patients in bone metastasis. This is already completed, so that's why they had the publication from JAMA Oncology, and now they are working on the FAST 02, which is also 10 patients for thoracic bone metastasis. So if you're interested in this clinical trial, this is the study published by Cincinnati Group about their first bone extremity results. And although it attracted a lot of attention, for flash radiotherapy, the current condition is people are actively working on preclinical trials, try to understand the mechanism behind the flash therapy, which means that you deliver the same dose but just much faster, and you some of the biological results show that there are some protection effect to the critical organs, but the target coverage or the tumor control rate actually stay the same. That's just to expand the therapy window for us. And from physics perspective, the flash therapy is focusing on the treatment planning. For example, for Proton, we're trying to do the transmission flash because we cannot do energy switching. We can only use single energy. That means we have to use the proximal and plateau region to deliver uniform dose. Also, we can do multi-field, just use a single energy Bragg peak, try to generate some uniform dose, but the dose heterogeneity is not as good as the SOBP. You can see from the DVH here, and you have like a large area has like high dose, and instead of like this solid line, which is SOBP, you can get a very uniform dose to your target volume. This probably is not, from clinical perspective, is not that important, because in the photon world, when we do SBRTs, we often have like very high dose inside of target. It's not a uniform coverage as well. So, but definitely need more explanation from animals and clinical trials. And the other effort actually have been delivered from vendor and physicists are the quality assurance program, which is like log file based, and how to increase the dose rate and how to make the dose delivery more reproducible. So there are a lot of things actually ongoing. If people are interested, would like to have collaborations, and also contact me. And we already had some study, but definitely there are more to come. Yeah, last slide just show you. This is the animal study we did, and just show you like a video how the flash beam delivered. Let me see if I can. Oops. The movie won't play for some reason. Oh, here. So this is a delivered 2.5 cm to 4 cm field, 14 gray to the animal. So you can see the dose rate is 76 gray per second, and how fast the delivery is. And people are actually keep pushing the dose rate to a higher level. So in summary, the unique dose deposition from Proton offers clinical benefit, and there are definitely opportunities to wider the therapeutic window and allows some challenge case that in the photon world to be treated in Proton in a safer way. There are uncertainties in the proton therapy. We cannot eliminate that. That's kind of intrinsic, but don't get discouraged. And there are always some kind of way to handle that. And the solution often can be like case by case basis. My personal opinion, the hypofractionation of proton therapy include SFRT, SBRT, and flash. Basically can be the future of proton applications and expansions. And if people are interested in research, those can be the directions to explore. With that, thank you very much for your attention. This is my contact information. If any questions that we cannot answer online, please contact me and we can have discussions offline. Thank you.
Thank you, Haibo, for the great talk. Any questions from the audience? Before taking any questions, could you please just quickly comment on the treatment time? I'm not sure if you mentioned that.
Oh yeah, good question. So let me just go back to the first slide. That basically is quite different to photon world. So you can see in the proton therapy center, we only have one cyclotron, which is the proton source. And because of that, let me just get, we only have one source here. And all the treatment room actually share the beam. And anytime only one room can treat patient. So because of that, it will slow down the whole process. Overall, for example, for 5-field head neck, we can have the total in-room time within 30 minutes. For DIBH, which is breast hold, very large lung or liver patient, we probably need 45 minutes. Prostate patient, we treat with 2 lateral beams, and quite simple. You know, you can do marker match, and in that case, we can treat the patient within 15 to 20 minutes.
Okay.
I have a question here.
Sure.
Okay, this is Bilal Shaheen from Beirut. I'm wondering about the benefit of proton therapy, especially the biological effectiveness, compared to newer modalities like electron flash. You know, nowadays people are talking about electron flash with 1.1 to 1.2 effectiveness increase. Could that be an alternative to proton treatment?
Okay, that's a very good question. So there are 2 things I want to point out. Number one, if we look at the physical property of proton therapy here, we actually, with the protons, by adjust the proton energy, you basically can treat the tumors at the various steps. With electron, at least the current clinical machines, you can only treat very shallow target, probably some skin cancers. But in the application of deep city target, proton has much more benefit. And secondly, for proton therapy system itself, there's no much modification you need to apply to deliver ultra high dose rate. The cyclotron can generate beam current up to 800 nanoamps, and currently in the treatment room we can have like over 200 nanoamps, which is enough for flash therapy. Nothing to modify in the whole system. But with electron, you probably need to modify, and also you probably need to design a different system to really treat with a relatively large target and deep seated. So those are the benefits of proton. That's why a lot of proton centers up running, and they can directly switch to the flash mode and then perform those kind of research like preclinical or physical research work.
Hi, I have a question. This is Sarah Zain from France. Thank you so much for the very interesting presentation. I have a question concerning the proton flash radiotherapy.
Yeah.
Well, first of all, does it require less time to deliver the treatment than regular proton radiotherapy? And the second question is, you mentioned that the spread out Bragg peak is not applicable for flash proton radiotherapy. Why is that? Thank you.
Thank you. So let's look at the SOBP first. I think we have this picture shows you. So SOBP, basically, you can see that we need to deliver one energy and then pause the beam and move the wedge pair in and deliver the next layer. So those switching from one energy to the next energy typically is around 1 second. So, compared to the typical radiotherapy beam delivery, it's not a big deal. 1 second is very short. However, when we deliver flash therapy, typically a single beam is within a second or sub-second, because it requires the dose rate to be 40 gray per second and above. And because the dose rate is dose divided by time, if your deliver time is longer, that means your dose rate is dropping, and you cannot reach to the dose rate threshold to trigger the flash effect. And that also answers your first question. For flash beam, the deliver is basically in the second range or sub-second. So I think the last slides I show you the video. That's one of the typical delivery of the flash beam, and I didn't slow down or speed up. So let me see. You can see how fast this delivery. And just based on the film itself, this is basically the speed of delivery itself. So I hope that answers your question.
Yes, thank you very much.
You're welcome.
Hello.
Hello.
I have a couple of questions. First of all, my name is Moayed. I'm from Jordan. I would to let you know I have a master's degree in medical physics, and my thesis was about pencil beam proton therapy, especially in lung cancer. So the subject about flash therapy, and maybe it's something new for to be applicable. So what kind of cancer can we use in using a flash proton therapy? This is the first question. The second question, I know I suggest you use some type of simulation. And it's I think it's Monte Carlo. You mentioned that. What is the kind of simulation that you use?
Okay, good question. So the first question is what kind of cancer actually can fit into the scope of flash therapy. And as I mentioned that there are clinical trials ongoing, and there are a lot of preclinical trials already performed based on animal. So people are talking about, based on preclinical results, people are talking about, proton, the flash therapy can reduce any skin toxicity. That's number one. And there are some studies shows that the flash therapy can reduce the post-radiation therapy lung fibrosis. So that means lung cancer treatment can be one of the option. And there are also studies show that based on animal models, if you irradiate the brain tissue of mice, and flash or non-flash show that there's a differences on the brain, the mice recognition after the treatment. That means it can protect some of the brain nerves and maintain the recognition capabilities. But all those are based on animals. You can see the clinical trials, from Cincinnati only be applied to the bone. And there was a real patient treatment in Europe about skin cancers that's based on electron therapy and show that very effective. So many of the study actually show the skin protection. So that could be like definitely something kind of like a consensus among all the teams. But regarding to a specific organs, and there are still a long way to go, especially how to translate from animal model to human, and that can be something like probably in the next few years. And we do expect there will be more clinical trials, and especially in US, And FDA actually is very careful about this clinical trials. That's why originally we planned to do long trial, and then they pushed to only bone on the extremity, on the bone on the thorax region. So hopefully, you know, based on these 2 clinical trials, we can consider next step. To your second question about simulation, there are quite some of the Monte Carlo simulations that you can do. I think recently I also heard there are some simulations try to simulate the biology process. So you know, if you're interested, I can find out more information and send to you about the simulation results. But for us, we actually use the it's called it's MedRed. This is also a free access open source, and you can modify this and then do the simulation of flash therapy. All our planning work actually based on this, and right now we are working with Variant to translate those works into Eclipse system. So Variant actually developed this called the Flex system specifically for flash planning. That's based on this work. Yeah, I hope I answered your question.
Yes, thank you very much. And yes, I'm interested. I hope if you give me that information you talk about.
Yeah, sure. Yeah, please
Thank
send
you.
me an email. I will reply you.
Of course, I
Yeah.
will. Thank you.
Yeah. Sure.
Could you please have a comment on the feasibility of proton therapy for biologic guided dose escalation? Like in the case of presence of hypoxia or highly proliferating zones within the tumor?
Yeah, that's a good question. I think it's definitely feasible. It's just a matter of how to do it more like online basis. We know in the photon world they are PET guided radiotherapy now, and in Proton actually not just those guided technique include the imaging technology are fall behind compared with the photon world. And you know, we hope the vendor can work with us and to really, you know, implement some of the technologies that we have in the photon world into proton world. I will see like hypoxia is one thing, and currently I think we can call it in New York Proton Center because all our head neck cases from Dr. Nancy Lee actually first treat 30 degree, and then they will test the hypoxia and then determine next step, continue treatment or 30 degrees is enough. So this is opposite to what we typically see, dose escalation, this dose de-acceleration. I mean, it's based on the patient hypoxic condition. Certain dose level is sufficient. You don't need to push to the next level, and because that introduces toxicity but won't increase the tumor or disease control rate. But besides that, I don't think we have any other application so far, but that doesn't mean that it won't be a possibility in clinic. But that's definitely a good point.
Any work in glioblastoma?
Probably not for neuroblastoma, and currently we only apply to the head and neck cases, not any brain cases.
Okay.
Yeah.
Any other questions? Okay. If not, the name of the organization again, I would like to thank you for the great presentation and hope to see you around.
Thank you very much.
Thank you. Thank you all.
Thank you all. Take care.
And see you next month, everybody. All right. Bye-bye.